The following episode is brought to you by the American Urological Association. The American Urological Association is accredited by the Accreditation Council for Continuing Medical Education to provide continuing medical education for physicians. For more information on how to claim CME credit or to view faculty disclosures, please visit the AUA University at auanet.org/university. This series is supported by independent educational grants from Astellas, AstraZeneca, Janssen Biotech, Inc., administered by Janssen Scientific Affairs, LLC, Lantheus Medical Imaging, Merck & Co., Inc., Pfizer, Inc., and Sanofi Genzyme.
Good afternoon. My name is Jay Raman, and I'm Professor of Urology at Penn State Health and Chair of the AUA's Office of Education. It's my pleasure to host another episode in our educational podcast series, with this specific podcast series titled Expert Exchanges in Genitourinary Cancers. Today's specific episode is titled PARP Inhibitors in Advanced Prostate Cancer Care, and it's really my pleasure to host two thought leaders in this space, Dr. Maha Hussain and Dr. Ganesh Raj. Dr. Hussain is a GU medical oncologist with a focus on prostate and bladder cancer. She's professor of medicine in the Division of Hematology and Oncology, Department of Medicine, and the deputy director and leader of the GU Oncology program at the Lurie Comprehensive Cancer Center at Northwestern University Feinberg School of Medicine. Dr. Raj is a urological oncologist with a focus on prostate and bladder cancer and is professor of urology and pharmacology at UT Southwestern Medical Center in Dallas. He has an active clinical program and a funded research lab that focuses on drug development and DNA damage repair pathways in prostate cancer. So first of all, Maha and Ganesh, thank you so much for taking some time to join us today. Both myself as well as our membership really appreciate your time and expertise in advance.
Thank you, Jay. It's our pleasure.
Thank you, Jay.
I just want to highlight a few of our key learning objectives for today. These will include describing the molecular basis for the use of PARP inhibitors in prostate cancer, identify approved PARP inhibitors for prostate cancer in patients who may benefit from such therapy. We're going to talk about safety and efficacy data for PARP inhibitors, indications and contraindications in patients with advanced prostate cancer, and finally, how to manage adverse events that patients may experience while taking a PARP inhibitor. So I think before we sort of dive into where PARP inhibitors are used for prostate cancer, and maybe even some of the data on different trials and indications, maybe I'd start off, maybe I'll start with you, Ganesh. Talk to us a little bit about why would we even think about using PARP inhibitors? What's the sort of molecular basis, and how does this sort of, mechanistically sort of fit into how we can target or treat cancer?
Sure. Thanks, Jay. So PARP inhibitors take advantage of this fundamental issue in a cancer cell called synthetic lethality. So what is that? So that means that a cancer cell, because it has a mutation in one pathway, is very dependent on another pathway, and that's what PARP inhibitors do, is target the pathway the cancer cells become very dependent on, and that process is called synthetic lethality, or manufactured lethality on that pathway. So what happened? The primary pathway that is affected are the BRCA mutations, and DNA damage repair mutations in prostate cancer. So when you have a DNA damage in a cancer cell, normally it's repaired through multiple pathways. One of them is the pathway that is dependent on BRCA. When you mutate that pathway, when you mutate a BRCA gene, that pathway is lost and it becomes exquisitely dependent on another pathway that the PARP inhibitors are then able to target and block. And if you're able to block the dependent pathway, the new dependency of a cancer cell, then the cancer cell cannot survive and dies. And therein lies the molecular basis of using PARP inhibitors in very select patients who have a DNA damage repair defect.
So Ganesh, I'm going to sort of the next step after that. So you've clearly highlighted for us mechanistically how PARP inhibitors work. What are the, and this is for either Maha or Ganesh, but what should we be ordering, or how do we recognize that a tumor or a patient has such a defect and therefore may be an adequate or a candidate for PARP inhibition? What are sort of the steps that need to occur if you have a patient in the office with advanced prostate cancer to know whether this can be potentially part of your armamentarium?
Well, if I may start for that, and then I'm sure Maha can talk more about the advanced prostate cancers. So let's start with patients with clinically localized prostate cancer. The bread and butter patient that we as urologists see, a lot more of them are coming to me now with a family history of prostate cancer, of metastatic prostate cancer, breast cancer, pancreatic cancer, or ovarian cancer.
Mhm.
Those four cancers are somehow higher risk of a man with prostate cancer having a DNA damage repair defect. So one of the things we do is we talk to those. Well, a lot of those patients will come in already with either a family history of a DNA damage repair defect, or like a BRCA mutation or others, and then they will come to you, and either they have also have had genetic testing done because their family was entirely genetically tested, and they will come to you and say, I have prostate cancer diagnosis with the BRCA mutation. What do I do about this? So that's a patient who is, you will see now more and more in your clinical practice with clinically localized prostate cancer coming with that diagnosis. So more patients at the outset are diagnosed with clinically localized prostate cancer. Now I'm sure Maha can tell us a lot more about the advanced setting, but
Sure.
that's what I'm start off with clinically.
And I think I fully agree with Ganesh. I think there's the issue of the family history. Definitely is a factor, and patients should be tested. And I fully agree, they have to be counseled. And different places have genetic counselors, so they can meet with them first. But if you feel that, you know, the physician feels comfortable, I think we should be capable of doing that. The one thing I just want to clarify that what we know about cancer is based on the knowledge of the last, say, 10, 15 years. There's a lot we still don't know. And there are many patients who get tested for germline, and despite a very, very intensive family history of highly suspicious cancers, their genes are negative. So when it comes to counseling, I think that's going to be important to say, just because you don't have the BRCA gene or the DNA repair defective genes type thing, that does not mean there's no risk for prostate cancer for your blood relatives and things like that. So definitely, I think we've entered the era definitely in the metastatic hormone sensitive space, and I would argue definitely in the front line and for sure in second line and beyond, in terms of counseling patients regarding the essentially the genomic testing of the tissue. And certainly if tissue is not available, then I recommend essentially doing liquid biomarker testing, so the ctDNA. And these are right now FDA approved. And in my experience, we haven't had any like insurance difficulties with doing it, as long as it's carefully documented in there. And definitely, I would say that is important because the data goes back to the Stand Up to Cancer effort, where essentially when the tumors, and these were frontline metastatic castration-resistant prostate cancer patients that had their tumors tested, somewhere around 20% of these patients had in fact had DNA repair pathway aberrations. And so I think that 1 in 5 will, for sure. And things the rate may increase over time potentially, but definitely I would say it's important to prepare, because it does take a while. By the time to get the tissue and get it sent, or collect the blood and send it, it's going to take a few weeks to get the results. So it would be good to do it ahead of time in preparation.
And Jay, just to build on that, I mean, I think those are important numbers to keep for a urologist to keep in mind. The prevalence of germline DNA damage repair defects. So germline is what you inherit, is probably in the order of somewhere between 1 to 5%. So those would be the numbers, especially for BRCA2, especially for the most common ones we know, is somewhere in the 1 to 5%. But in the therapy-resistant, metastatic, castrate-resistant prostate cancer, it's close to 20%. So you're talking about a small number of germline and then a bigger number of patients with what we call acquired or somatic or and plus germline. That equals 20%. So it's 1 to 5% here, 20 to 25% there.
And then to highlight actually the fact that I fully agree with Ganesh, that is from the perspective of the overall population. Where we sit in as medical oncologists, we tend to see the bad disease by default. And so if one goes by the data from the different published data, the range is exactly 1 to 5, but in the stand up to cancer was almost up to 10%. There were pathogenic germline findings. And again, part of it is because the stand up to cancer was a self-selected group of bad aggressive disease because they were already castration resistant when they got seen.
So give our listeners, so we're going to obviously be spending a lot of time talking about PARP inhibition and prostate cancer, but just to take a step back, maybe give our listeners a little bit of a sense of what other disease states, cancer disease states, is PARP inhibition currently used in? And it may just be helpful to know that, you only know what you know, right? So urologists and urologic practitioners look at the urologic diseases, but maybe give me a bit of a sense of where else is this being used? What other diseases, what other malignancies?
Oh, so I mean, the first story began actually in ovarian cancer. And in fact, there is a very nice paper, if the audience is interested, that was published in JCO Precision Oncology in 2021, where Mark Rubin was the senior author, and his team, they basically reported the history of PARP start. And the research actually started literally in the early 60s overall. But where the implementation occurred is ovarian cancer and breast cancer, and then more recently, pancreatic cancer, and of course, prostate cancer.
So let's talk now about a little bit more about prostate cancer, and maybe let's start with, and Ganesh, I think you started talking about this a little bit, or maybe Maha, you did as well, but can you give the listeners a sense of where should PARP inhibition, or at least now, and that may change over time, and things seem to always move earlier into the disease paradigm, but right now, if you look at, say, NCCN guidelines, or where does PARP inhibition play into patient care, and maybe also what are the trials that help us inform that's where they should be, or they should be used in clinical practice?
Well, a lot of we're fortunate to have Maha here because she was involved in PARP inhibition in prostate cancer for a long time, including the initial veliparib study and so on. So, the only thing I can add to this, and she can tell you a lot more about this, but one of the key things I can tell you more than anything else is PARP inhibition is currently FDA approved and indicated for patients with metastatic castrate-resistant prostate cancer, and so it is with a BRCA mutation, with a DNA damage repair mutation. So it has to have two parts to it. One, they have to be metastatic, castrate-resistant, and two, they must have a somatic, biopsy-proven, or through cell-free DNA or some other method, some evidence of a mutation in a DNA damage repair defect. So that is the primary indication as it exists. But Maha can tell you a lot more about each one of those trials and what those trials mean.
Sure, absolutely. I would be more than happy to. So I just want to reiterate what Ganesh mentioned. The interest in actually looking at PARP and prostate cancer literally began over 10 years ago, easily, I want to say from the late 2000s to early around 2010 and so. And basically, the data was becoming more and more available, looking at the mediation of DNA response in the setting of alkylators. So essentially, you're creating that artificial synthetic lethality with the DNA damage and with the alkylators. And then, of course, emerging data regarding the BRCA-like genes and so on. And basically, work from Karen Knudsen and her team actually also elaborated even more about how AR and the PARP pathway interact, and so that you get the AR, there's mediated prostate cancer cellular proliferation, where you find is PARP1 interacts with the AR with the androgen signaling cascade, and castration-resistant tumors actually exhibited higher rate of PARP1 activity. And so this is actually when Ganesh was referring to veliparib. In fact, that's what started the first trial that I did in combination to try to combine without a pre-selection, combine patients looking at adding abiraterone and veliparib. And this was part of the Stand Up to Cancer. And what was fascinating, actually, the patients who had enough adequate metastatic disease tissue, we had them sequenced and looked at responses. And surprisingly was the fact that the patients who had the DNA repair defects seemed to respond better, irrespective of whether they were on Abi or Abi plus veliparib, which was kind of odd there. Now, one of the issues when people ask me why did veliparib not work is partly because I don't think all PARP inhibitors are equal. And in fact, we did a review on the subject, which I'm happy to provide the reference for separately to you all and to the audience, is that there's all kinds of different DNA repair genes, and there are different agents, and not all are equal in that regard. And so, so the work in prostate cancer really dates back to that. Now, where there is the FDA indication at this point, it's with two drugs, olaparib and rucaparib. And with the rucaparib, it's strictly approved in the context of patients who have the BRCA1 and 2, basically. So essentially the BRCA germline or somatic, and olaparib was approved in a 14 gene panel, basically. So the usual suspects type genes, and clearly BRCA1, 2, ATM, and all of the rest of them. The one thing I want to point out is that, and we published on this, is that it's important to counsel the patients. Just because somebody has the BRCA doesn't mean there's a guarantee 100% they're going to respond. That's one thing. The second thing is, technically speaking, right now, the approval is technically in the second-line castration-resistant disease. And there are, more than happy, we can go over different trials that are happening even in the hormone-sensitive space, high-risk, local relapse type situation, and so on. And so I think there's a lot of work that's going on, and I'm hoping that within the next few years we will hear much more about it.
Yeah, maybe you could. Oh, sorry, go ahead. Were you going to say something?
I was just going to say that, one of the things in urology, with that tendency to move everything up front, there is also this huge impetus to move all these drugs further and earlier in the course of disease. One of the things that you might want to consider is also think about, in the clinically localized disease, especially when a patient comes in with a known BRCA germline mutation, should you give that patient a radiation or surgery, or what should be the first treatment, or should you incorporate a PARP inhibitor? And the only way to do that is in the context of a clinical trial. But that is where the field as a whole is moving. So kind of skating to where the puck is going. That's sort of a futuristic view of the world, rather than just thinking about the metastatic CRPC.
Yeah, fully agree. And I think this is where I would say we need the data, because not all diseases are equal. And certainly extrapolating from the castration resistance space is one story. We've lived the story of different drugs that got moved up front and they did not work as well. So I do think clearly when there's the opportunity for patients to be offered clinical trials, that would be very, very optimal.
So I think you both hit on this point that we've seen in the landscape of prostate cancer, right? That a lot of the therapies that are currently being used earlier and earlier initially started in the castrate-resistant space and now have moved to the hormone-sensitive space. And Maha, you mentioned this a little bit, but maybe just give our listeners a little bit of a sense of maybe some of the trials, either Maha or Ganesh, some of the trials that are out there that are now incorporating PARP inhibitors maybe earlier in the treatment paradigm, and when we think such trials ballpark would accrue to, like when would we start getting some data on some of the use earlier in the treatment setting?
So, for those who might have attended ASCO GU this year, there were two clinical trials that were presented. One is Propel trial, which was evaluating olaparib in the frontline castration-resistant disease. So it's Abi plus minus olaparib, so placebo versus olaparib. And then the other trial was the Magnitude trial. And again, the control was abiraterone. And there was somewhat of a mixed outcomes in some way with the trials. And then I think part of the problem too is driven by the design issue. So the Magnitude trial was, I would argue, better designed in that it was an a priori stratified and then randomized trial, looking at the value of abiraterone with niraparib or abiraterone plus placebo in the context of frontline castration-resistant prostate cancer. And that trial basically showed there was potential benefit, there was benefit in the patients with the mutations as opposed to those who had the intact tumors. The other trial was the actual Propel trial. And the Propel trial in that regard was not as, I would say, optimally designed in my humble opinion. And the reason I say that, it basically took all comers, randomized them, and then basically collected samples and tested and, on patients, but it wasn't a priori stratified. And as you can imagine, for those of everybody, including us in the clinic, when we test samples, there's a lot of sometimes issues with the sample resulting there, or not good quality, or all kinds of stuff. So that might kind of give a sense that there could have been sort of indirect misassignment, so to speak, of the patients in the different arms. The bottom line is this, is the combo is better than the single agent. And again, I would say the signal from the niraparib is more clear where the benefit is. Propel, the claims is that it's across the spectrum. Mm-hmm. And so my understanding that the data is before the FDA, as I hear. I don't know what the verdict is going to be from the FDA on the subject. So we'll have to be, staying tuned. When all is said and done, again, I think at the end of the day, in making decisions for a patient, one has to go by the data, appropriateness for that individual patient, risk benefit, drug interaction, and multiple other factors.
And Jay, kind of building on that, I mean, right now we have two FDA-approved PARP inhibitors for prostate. We have olaparib and we have rucaparib. There are two other ones that are in trials, the niraparib and talazoparib, and those are both in trials. If you look at the number of trials on clinicaltrials.gov for prostate cancer, for PARP inhibitors in prostate cancer, there are more than 30 trials. And most of them are in the advanced metastatic castrate-resistant setting, either as monotherapy or in combination. There are also a trial that hasn't accrued yet, but it's the neoadjuvant setting for high-risk, clinically localized, unfavorable parameters for those patients trying to use a PARP inhibitor in the neoadjuvant setting. Again, looking for either P0 or near P0 rate in combination with an anti-androgenic agent.
And of course, there's all kinds of combination trials with immune therapy, with radium, actually, with lutetium, PSMA, PET, therapy with all kinds of different drugs. So I do think it's really exciting time. And I do think I don't think everything is going to be positive, but I do think certain areas will likely be positive. And that, I think, will make a huge difference. And when it comes to the hormone sensitive space, exactly as Ganesh pointed out, the issue, I think, is going to be for the early stage high risk disease is one thing, because I would imagine you're not going to treat them forever. The issue is going to be in the setting of the hormone sensitive relapsed or metastatic hormone sensitive space. And the issue comes up giving these drugs, there's one thing about giving AR inhibitors lifelong. How do you go about giving a PARP inhibitor and the issues of downstream bone marrow issues and things like that? So I think there's a lot of questions that we need to address.
So practically speaking, just when you look at these drugs at administration, how are these given? And is there like a dose escalation sort of process? We just really practically, how do you give PARP inhibitors? Is it a fixed dose? Do you escalate the dose? And then what's sort of your criteria for monitoring treatment effect?
So the dosing is essentially for the approved indications. The dosing is based on what the FDA approval is. Having said that, there are times where if you're uncomfortable about giving somebody because you're worried about, they've seen all kinds of chemo before and there is issues, you can always start at what I call a -1 dose level, depending on which drug one is going to go with. But I would say in the vast majority of times, honestly, more than 95% of times, one is able to start with the full dose and then adjust dosing based on the patient's tolerance. In general, I have to say, for properly selected patients, the toxicities are not as, they're I'm not going to say mild, but they're really not something that's prohibitive. And definitely, I would say most of my patients are at full dose at this point. And many of them actually some are on clinical trials, some are not, but some of them have been on treatment, without exaggeration, for 2 to 3 years. And these are the classic, what I call exceptional responders, the BRCA2 patients.
Just to build on that, these are orally administered also, don't have any food restrictions for us used to giving Abi and enzalutamide. These are orally administered, usually once or twice a day, usually twice a day, and then no food restrictions and no need for concomitant steroids.
Yep.
So, I think what, I would hazard a guess that at this present time, most urologists, for example, may not be prescribing PARP inhibitors. But I think that most urologists probably have patients that they share with their medical oncology colleagues, right? They probably passed through the disease spectrum. At one point, they were localized, and now they've moved on. So I think what urologists and urologic practitioners will see a lot is the adverse effects, the side effects, right? Patients are calling in and they have X, Y, or Z side effect from therapy. So maybe can you both talk to me a little bit about what are the side effects of the PARP inhibitors? What do people need to be cognizant of when, I don't know, the phone call comes in or laboratory testing needs to be done? And how do you manage these side effects when they occur? Maybe that's for Maha, just in your practice.
Can I just say one thing before Maha says? The only thing I remember as a urologist, when a patient calls with one of these, the most common one that we've encountered is anemia. And my next call to them is called the medical oncologist. So Maha?
Yes, you guys do a good job dumping on us. What can I say? So I fully agree. I think if one goes by, let's say, the olaparib, just because that's the broader indication, the most common high-grade adverse event or any grade adverse event in total was actually anemia. So I fully agree with Ganesh. And clearly, I think the anemia is multifactorial. One is the fact that a lot of times where these drugs are given are pretty much in patients who have seen prior chemotherapy and so on. So their bone marrow is already kind of affected. And on top of it, of course, there is the myelosuppression that can occur. So I would say, based on the PROfound trial, when we saw it, it was surprisingly that this is, again, an international trial, and the treatment was incredibly very well tolerated by the majority of the patients with no major issues there, but anemia was the most common. And I think the issue is going to boil down to, for the physicians to definitely connect with the medical oncologist, just because this is part of what we handle in general. Another thing that I've seen with patients, and certainly reported in the trials that we have done, was really the nausea and fatigue. And some patients kind of have, some other symptoms that are kind of not specifically what you would expect, like, aches and pains and things like that. And some of these things may be a function of the fact is the cancer is just when a patient is on a trial and they have a symptom, their physicians are going to, basically potentially say potentially related kind of thing. But I would say the marrow suppression is the biggest issue. The fatigue is another thing. And this is where I would say judgment has to be used in terms of management. So the potential would be if things are like, say, severe anemia is one thing, but a mild anemia, maybe there is the room to continue. And then if the patient can qualify for a transfusion, go ahead with it, with the hope that as you do the treatment, if somehow the drug works well, the marrow may recover, and then you won't need to reduce the dose. The flip side would be is obviously if there's concern, definitely safety trumps everything. And so if there's any concern, one can go down and then give it some time and then potentially go back up there. But I would say this is the kind of these drugs, even though they are pills, they're not, abiraterone, and so or enzalutamide. So I would say definitely partnering with your medical oncologist is going to be critical.
Maha, could I ask a question? The fatigue level that you see with these drugs, would you say is as profound as, say, what you see with enzalutamide or any of the other drugs?
Actually, no, surprisingly. I would say that with Enza, you feel patients have a fair amount of fatigue. Certainly when we give chemo, in the first couple of weeks or 10 days, the patients kind of feel like really weak. This is not that way. And I would say that, as I said, I've had several patients, and again, these are the exceptional responders, so you could look at it from that perspective. One patient actually has been on it for 4 years. Another one is on it for 2 years almost now. Surprisingly, no anemia, not requiring transfusions, no issues with platelets or anything else. So again, there is all of these spectrum of things, but obviously I would definitely say these are unusual, more exceptional type responders. I would say for your average patient, especially when these drugs are given in second, third, fourth line type situation, one needs to be prepared for potential adverse events.
So Ganesh, when you started us off, you talked to us a little bit about the mechanisms of PARP inhibition, right? How do PARP inhibitors work? So I'm going to maybe flip the corollary to you now, which is what are sort of the mechanisms of resistance? What happens? It seems like this is an elegant therapy. It's targeted, right? It's far more targeted than just global androgen suppression. But what's the mechanism of resistance? And I don't know. Is there any data on even in a basic science model, like how often does that occur?
Resistance is almost always the case, right? Like, except for the exceptional responders, you almost always have the resistance. And resistance, actually, if you think about it, they're almost always reversion mutations. So what's a reversion mutation? So if you have a point mutation in the BRCA gene, then you get another mutation that restores the function of that gene. So what it does is, remember, the BRCA gene basically blocked one pathway. The mutation in the BRCA gene blocked one pathway. The reversion mutation restores that pathway. So that pathway for DNA damage repair, the PARP inhibition can block another pathway, but the original pathway that the BRCA gene was blocking is unblocked because the gene became reverted, and now there is a pathway for the original DNA damage repair to happen, and it's almost like your PARP inhibitor loses activity. It's the effect of it's effectively like giving a PARP inhibitor to somebody without a BRCA mutation.
Yep. And it just tells you why humanity survived millions of years. Is that adaptation, for sure.
And then Maha, my related question to Ganesh is we talked about indications, right? We talked about NCCN guidelines. What are the indications now? What are the indications in the future? What are the contraindications? Who really can't get a PARP inhibitor? Are there specific persons that can't? And who are those persons?
Well, I would say for a general statement, anyone who you think you're going to harm when you're looking at them and trying to decide to give them treatment, definitely should not be done anytime you're nervous about giving it. Having said that, I would say patients who have, there are times where we see patients who have, let's say, uh, uh, leukemia. And they're already, in fact, I have few of them, patients. And the issue comes up is they already have, bone marrow issues. They already have the leukemia. And are you going to make things worse? So there's going to be some potential cases where you feel, or MDS or something like that, where you're going to have to figure out. And honestly, none of us, I believe, have any experience, nor that I've seen any reported data at this point, just because the trials pretty much excluded these types of patients.
So maybe in the last 2-3 minutes here, I'll ask you each, maybe I'll start with Ganesh, sort of take home message for our listeners. I mean, what should they walk away from in your perspective, just regarding PARP inhibition and advanced prostate cancer? And I'll start with you, and then I'll go to Maha with her parting thoughts.
Yeah, no, that's great. So I think one of the key things, Jay, is that we are going to see more and more patients with the DNA damage repair mutation, with a BRCA mutation, with an ATM mutation showing up to your practice. I mean, and either to think about whether that increases their risk of prostate cancer, whether you're going to survey them more actively with PSAs, set them up for biopsies more often. This is pre-diagnosis. You're going to see more patients. Second, you're going to see more patients with prostate cancer who already know they have a BRCA mutation. How you treat them is also going to be important. Knowing fully well they have more aggressive disease, higher risk of recurrence, higher risk of metastasis, higher risk of long-term in sort of a smaller cohort of patients. That's what the data tells us so far. They have more aggressive cancers. So, given that, how do you treat that? And then the next part of it is in the advanced setting. Once you become castrate resistant, if you start sequencing your patients, the metastatic sites, you will start finding a lot more of these BRCA mutations. Then you call in your friendly medical oncologist, Maha, for further support.
No, send them to your local oncologist. Don't send them to me. So one thing, Jay, I wanted to mention for your previous question about who should not get it or whatever, I do think that a lot of these drugs, including like when we give Enza or Abi or whatever, there is issues of drug-drug interaction with medications that the patients are on. So I do think that it's going to be very critical for the managing physician to consult with their pharmacist regarding the potential drug interactions where whatever the patient is on, because obviously that can create a major issue in terms of side effects, and that's going to be important. So that would be the answer for the previous one. I think that we've entered the era of precision medicine in prostate cancer. I do think that the field is evolving quite rapidly. And I think at the end of the day, the goal is not to replace treatment. The goal is to give the patient the best chance of response and maximizing their chance to live longer. And so one thing that I have seen sometimes where people kind of say, well, you're better off with this as opposed to getting chemo or something like that. The reality of it is all of these tools are on the table to offer patients. And depending on the timeline, the comorbidities, the cost factor, insurance coverage, patients' abilities, and things like that, all of these things ought to be taken into consideration to try to maximize the chance for the patient to respond. None of these treatments are curative at this point in the setting we're dealing with. And so I do think that has to be sort of taken into consideration when a decision is made for a patient.
That's great. Very well said. Well, I want to, Maha, Ganesh, I really want to thank you both. I think you did a really absolute fantastic job summarizing, I think a space that most urologic practitioners probably feel a little bit uncomfortable in is when you get to this advanced prostate cancer realm, and especially sort of new targeted therapies like this. But I really want to, first of all, thank you both very much for your time and your thoughtfulness.
Thank you very much for the opportunity. Absolutely. It takes a team, my dear. So for sure. And that's what's important.
And to our audience, thank you very much for joining us. For more information, please visit us at auanet.org/university. Maha, Ganesh, I hope you both have a very happy and safe holiday with your families.
Thank you very much. You too. Bye-bye.